Thank you. Good afternoon. It's afternoon, right? Yeah, it is. Good afternoon. So we want to continue from where we left in the morning. But this time around, we want to talk about fetal defects. This is the roadmap I want to take you through. I want to make sure I finish before it is one, right? Or just after one, so that people don't blame me for a late lunch. So I'll share with you the burden in terms of the local cohorts, what we've done in our work, and also the organ systems that we come across more often. Then I want to talk about detection of fetal defects, both first, second, and third trimester. And I also want to talk about investigations, screening versus diagnostic tests, and also the counseling and the care pathways that the patients go through whenever there is a defect. Whenever we make diagnosis, the diagnosis must lead to prognosis, counseling, documentation, and a pregnancy care pathway. When we started fetal medicine, I used to have problems with my colleagues. They would actually say, I just wanted you to scan. Why are you telling me how I should manage the pregnancy now? Then I would say, no, that is my job. I have to tell you how the pregnancy is managed because there's a problem that is in my domain where we have to discuss the care pathway. Say, how should a pregnancy with this defect be managed for a better outcome? But we are happy that now people do understand this, that it's a domain that requires a lot of time, and also that requires investment in time that normally, if somebody is practicing obs and gyne, you won't have the time to invest enough to be able to be confident to talk about how this pregnancy is managed. So that is our job, to make sure we take away that burden. The question is, why fetal defects matter? They matter because they contribute to under 5 mortality. And this substantial burden is in low to medium income countries. I've just shown you some figures from WHO here. What you will notice that as the other conditions of death have improved in other countries, one of the standout things that you notice that there has been a rise in the fetal defects or congenital anomalies as the cause of why babies do not make it. Let me get a point out. That way I can. So we can see that there is a rise in the contribution of congenital anomalies. They contribute up to what? Up to 30% in these graphs here. So it's a big burden we have, and unfortunately in Africa, most babies are underdiagnosed or undiagnosed, and these defects are actually hidden. If a baby has, let's say, probably bilateral hydrothorax and is in Chicombedzi where probably no scan has been done, this baby already has some hypoplasia of some sort, pulmonary hypoplasia. When this baby is born and demises in the early hours of birth, the cause of death is going to be recorded as unknown. This is why you see, if you look at the pie chart of our national mortality, the unknown cause of neonatal mortality contributes something like close to 20%. But in obstetrics, we know that what you don't know, you can't find solutions to. You can't solve what you don't know. So if 20% of our babies are dying and we don't know why they are dying, that's catastrophic, right? So this is where we are coming through to say anomaly scans should be done the way they are supposed to be done, so that we can make a dent into this 20% of the unknown cause of why babies do not make it. Just to show you our own cohorts, to just convince you that indeed fetal defects okay, and they are real, and they are amongst our people. So you can see from the 9,513 pregnancies scanned, we have now scanned more than 30,000 pregnancies, but I'm just showing the data of 9,513 pregnancies here, where we had 176 fetuses with defects. And the total number of defects was 340, which was an incidence of 2 in 100. And I think this 2 in 100 is what is commonly caught in most publications whenever defects are mentioned. Out of this cohort, this is the distribution in terms of the systems. So from this cohort, we analyzed, we noted that central nervous cardiovascular system was leading in terms of the defects. And as you can see, I think there's been a mix-up of figures, but central nervous system was number 2 in our cohort of defects. So the defects actually do exist, and they occur everywhere where pregnant women are. If you are working at a center that probably delivers 2,000 women a year, just know that on average in your center you should expect probably to see something like what, 200 defects in that center. If you are not seeing them, then they are being missed. That is what it means. So to just show you again the other systems, these are the pulmonary hypoplasias, the VSDs, tracheoesophageal fistula, AVSD, aortic stenosis, Arnold Chiari, ventriculomegaly, acranias. Everything that they taught you in embryology does exist. That is all I want to put across. Because sometimes when you read books and you don't experience what you read, you think books speak of things that do not exist amongst your people. But they actually do exist, all these defects, and they are there to be picked. So to show you the other system, that the defects occur in almost every other system that you can imagine, including the very rare abnormalities that you read in textbooks. We've come across them in our line of work. So what is the approach across pregnancy when it comes to screening for fetal defects? First of all pregnancies ideally should be optimized. In other words, women, whenever a woman decides that I want to fall pregnant, the ideal thing is that a woman should go and see a doctor, preferably an obstetrician, and talk about their plans to say, look, I want to get pregnant. Women may have risks that they don't even recognize that they have, even if it's their first pregnancy. So pre-pregnancy evaluation is standard that every woman should have it. Women may burn drugs that they don't know that is not good for their babies, and they may go on and fall pregnant, and this may result in fetal defects. Most women's diet is already deficient in folic acid. Why? Because we all boil the vegetables until they change color. The moment we do that, we're burning away the folic acid, and probably we eat the wrong fruits which do not have enough folic acid. So all these are the reasons why women should go for preconception evaluation. So after this preconception evaluation, the journey of screening for defects on the baby itself will start at the 11 to 13 week scan. Yesterday we had the opportunity to demonstrate how we do it. How we screen for acrania, how do we screen for anencephaly, how do we screen for hypoplastic left hearts, and how do we screen for myelomeningocele at the 11 to 13 weeks. Then after the 11 to 13 weeks, they again come back at the 18 to 24 weeks and they get a screen. Then they come again at the 36 weeks and get another screen. That is the pathway for screening for defects. I know the teaching has been the anomaly scan, as if that's the one silver bullet that is supposed to screen for all defects. But I want to prove to you that is not correct. Let's look at Agiro Singulak's work. When Agiro Singulak looked at the database of 100-something thousand women that were being scanned at the fetal medicine units at King's College, she noted that in first trimester there was a detection of 27.6% of defects in the first trimester. And which were the defects that were being detected in first trimester? If you look here, these are the highly detectable defects: the acrania, the alobanholoprosencephalus, the encephaloceles, the exumphalos, the gastroschisis. So these are first trimester diagnoses that everyone who is coming according to protocol should be able to detect. So picking up gastroschisis at 20 weeks, holoprosencephalus at 20 weeks, is too late. It's already late. They should be picked up at 11 to 13 weeks. Then the other ones that can be detected with the moderate detection ability open spina bifida, these are the myelomeningocele. Yesterday we're demonstrating the BSOB ratio, the brain stem hospital bone ratio, where we were saying it's a screening tool to screen for myelomeningocele. Then the hypoplastic left heart, the AVSDs, the complex congenital heart defects, and the lower urinary tract obstructions. These can be picked with moderate detection ability. Then the ones we know, they will not be able to be picked up with certainty, or they are likely to be missed in the first trimester. Conditions such as ventriculomegaly, agenesis of the corpus callosum because it develops later, the CPAMs, the cystic pulmonary adenomatous malformations, the renal anomalies, and the talipes. We know we may not be able to pick up this. Hence, the 12-week scan, while it picks up the other defects, it may miss some. This is why they have to be brought again at the 20-week anomaly scan. So again, if we continue with our Aguirre single axe work, we see that the detection ability, this is the overall, I'm not talking about system. There are some systems where the detection is very high for certain defects. The overall detection of all the composite anomalies was about 53.8%. And which ones were more likely to be picked? We can see the VSD, AVSDs, the outflow tracts of the heart, the ventriculomegaly, the agenesis of the corpus callosum, the neural tube defects, the hydronephrosis, the multicystic kidneys, the cleft lip palate, dysplasias, and the skeletal dysplasias, limb and posture defects, the bowel obstruction, abdominal cysts, and why is the yield almost 2 times? It's because the organs are larger, planes are clearer, the bones are less ossified, so the views are better, and the defects themselves are evolving in a way that allow people to see them. Right, let's go to third trimester. In the private sector, we no longer bring them at the 36 weeks. We still do it in the public sector because we fear the burden it will give us, but in the private sector, we now bring them at 32 weeks because we have learned something over the years. When you reflected on our work, that there are some babies, you do not tell people at 36 weeks that there's something wrong when you can pick it up early. Mostly in the private sector where the bar is very high, right? So what was detected, 2.1% of the defects were detected for the very first time in the third trimester. The question now is, why? Because certain defects do not evolve before third trimester. I'll give you examples. Even babies with achondrogenesis, you know, the ones you call the dwarfs. Yeah, at 20 weeks, those bones will be just borderline. In the hands of most people, they are normal bones. But they begin to shorten after 25 weeks. So an anomaly scan may pass a baby with achondroplasia. So that if they don't have any other scan, when they come at the 36-week scan, that's when people discover that there's achondroplasia. Other defects like ovarian cysts, babies who have ovarian cysts, girls, they have ovarian cysts. They will not have it at the 20th week because the hormones won't be playing a very big role then. So you may bump onto an ovarian cyst. Microcephaly is a third trimester diagnosis. So we still need an anomaly scan at the third trimester. Vein of Gallen malformations. It's a very terrible condition with very high mortality in our hands, or in our, not in our hands, but in our country. It's 100% mortality for all the babies, whether both public or private. They've all died, the ones who have diagnosed. But it's a third trimester diagnosis. In the second trimester, there's nothing you will see there. But in third trimester, then you begin to see that there are some cystic structures in the baby's brain, and when you put on the color, you see all these malformed veins in the brain, right? Mild ventriculomegaly, again, you miss it in second trimester because it will be normal. It will manifest later the duplex kidneys, the hydronephrosis, and some of the VSDs. So these are late findings. So that means when women come in third trimester, they also need an anomaly assessment because of what we are learning from this week. So what does it mean? It therefore means that The first trimester will allow us to pick severe early defects, because it's not right to tell a woman that you have got anencephaly at 20 weeks when it can be done at 12 weeks. Because my clinical psychologist colleagues will tell you the mental effects of telling these women that everything is not okay when they've already done the preparation, they've colored the rooms, they've gone to Dubai to buy nice things, and you told them that your baby is not going to make it in third trimester and there's no brain. It's unimaginable, right? So this is why we are talking of first trimester. Once you have done the first trimester, we also do risk stratification. This is where women also volunteer to us, say, Chiremba, I've been taking losartan. I'm hypertensive, right? Yeah, which is a very common drug which physicians love so much, but we know it poisons the baby's kidneys. So these are the women then who say, I will flag you and I want to monitor your kidneys as you stop the losartan and see if they will recover or if they will continue opening up, right? Then the second trimester is the most high yield scan and they have to have it. Then the third trimester is there to check for the late evoluting conditions and some occult defects. So in other words, there is no single scan that detects all fetal abnormalities. A staged trimester-based strategy gives the greatest diagnostic value and will increase our detection rate. So what am I trying to do? All I'm trying to do is I want to dismantle the old system whereby people will pick one scan and say the anomaly scan at 20 weeks is the only scan that a woman should have. And I also want to dismantle the notion that women need one or two scans, because you will find it when you read the literature or when you read some national documents that people talk of one scan. But I want to dismantle that, because I think women should be given the best standard of care available. So once we have done the anomaly and we have picked up this anomaly, the next thing is, what is the screening strategy and the diagnostic strategy? Normally, we highly recommend, especially in the private sector, which I want to encourage everyone here, that in the private sector, offer the clients you see they're the best. Don't offer them suboptimal. So what is the best we offer? We offer them NIPT to say, look, we know that babies with Downs, 20% of them will hide us from us on scan alone. Because only 80% of babies with Downs will show you something suggestive on scan. The 20% won't. So we tell them the 20% will hide from us. So as a result, we can't guarantee you that your baby is not in the 20%. The only way for us to be sure that your baby is not in the 20% is for us to do fetal cell-free DNA test. Because the fetal cell-free DNA test, the NIPT, will allow us to pick these 20 that we couldn't even suspect on scan. So we offer them the fetal cell-free DNA test at 10 weeks. So when they come to us at 12 weeks for this scan, we are already assured that this baby is not in the 20%. So that when we tell them that, look, we've checked your baby and the findings are reassuring, we have this layer of coverage. You don't have this mango on our back. Because if you don't do it, you always have a mango on your back. They're saying, what about if this baby is on the 20% and when the baby comes out, you know how it works, that if the baby is born with Downs, the first thing is, we're going to fit our clinic, Dr. Verenga scanned us, but our baby was born with Downs. Right? This is how the stories are formulated. But for a layer of security, we have to declare this. So look, 20% will miss if we don't do fetal cell-free DNA test. And believe you me, women are doing this test. However, it doesn't exclude copy number variants, the single gene disorders. So when we do the scan, the next thing, whenever we have a defect, we want to know, why do we have it? I'll show you on the next slide the association of defects and chromosome abnormalities, but we have to subject the woman to these diagnostic tests. I'll explain them later. And then they also have to be cancelled by the counseling team who give the additional counseling. This is the genetic contribution to malformed fetuses. Because some people may wonder and say, you have already diagnosed the defect. Why are you bothering these women by doing further tests? We are doing these tests because we know that 25% of babies' defects will have chromosome abnormalities. Then the other 8% will have sub-microscopic copy number variants. What do we mean? What we are saying is, when you do karyotype, conventional karyotype, and you say there's a translocation or there's a duplication translocation, it's because a large chunk of the chromosomes is duplicated or translocated. But if there's a small portion of it which is translocated or duplicated or deleted, you are not going to see it using conventional karyotype. It will be missed by the laboratory. But we know that these small duplication deletions are associated with the defects. So this is where the issue of chromosome microarray comes in. So chromosome microarray is zooming in further than what a conventional karyotype do. I know most people were taught on conventional karyotype, but it is now well known that the conventional karyotype is not the best answer to babies with defects. Because a substantial of them, 75% of them, will come with a normal karyotype. But that does not mean the gene is normal. It's just that we have used a superficial test that is not looking deep enough. Right? Let's unravel this. Then the other 10% will have single gene disorders. The question now is, what do we do with the single gene disorders? This is where we are now doing the whole exome sequencing. Let me jump this, right? Let's go to this, because I'm talking about whole exome sequencing. So this is where we do the whole exome sequencing. What are we doing with the whole exome sequencing? With the whole exome sequencing, if we do not know, if there's no family history that tells us that probably there's a history of hemophilia and we want to screen for hemophilia, or there's a history of this condition, then the laboratory cannot do any directed testing, cannot do this single gene targeted testing. So this is where the whole exome sequencing. What is the whole exome sequencing? We were taught, is it physiology, that only 2% of our gene codes for protein or makes us who we are. Only 2%. So now, the sequence of the nucleotides are the thymine, guanine, adenine, thymine, cytosine. That arrangement of the nucleotides was studied when the whole genome sequencing project was done almost 15 years ago, right? Around 2012, that's when it was completed, right? So it is now known how the human genome nucleotides are arranged on the chromosomes. So this test we are saying whole exome sequencing is going out there to check if the baby's arrangement of these nucleotides, these building blocks, is conforms to what a normal human being should look like. So this is the level of testing we are carrying out. We should be given to women, because people need answers out there. People need answers. It's not good enough to tell women that your baby is a defect and they'll tell you what has caused it. You tell them, I don't know. It's not good enough. People need answers. So why is my baby not normal? So this is the level of testing that we have to do. But let's also remember that it is now known that the other 98%, which we were thinking is a redundant genome, can actually cause disorders, because these are control promoting proteins, structural supports. If they are abnormal, they can also cause a variation in the phenotype. So this is where the whole genome sequencing comes in, where the whole nucleotide arrangement is going to be studied. And these tests are already happening in Zimbabwe. There is a rare disease clinic run by our pediatric colleagues at the university, where they are offering whole genome sequencing to babies with abnormal phenotypes or genetic syndromes when they are born. It's run by Dr. Kandawashika, this clinic. So they are running whole genome sequencing on babies we do not understand. To say, oh, how is this baby? They are doing that. So these are already happening. So this is what babies with defects will go through to try and understand what's going on. These tests are run, and we are doing them in Zimbabwe. Because people will think, they don't understand, they don't exist. They do exist. Once we have defects, we categorize them to say, is this a minor, is this a major, lethal or non-lethal. I've just put them in category to show you sort of groups. These are not all the defects. There are more than 200 defects we can pick on babies. But to just show you the common ones, say when you see this defect, where does it sort of fall into? So you will see that these ones are lethal. The anencephaly, the alloboloplesencephaly, probably close to semilobar, but semilobar causes severe mental handicap, severe pulmonary hypoplasia, body stroke anomaly, bilateral renal genesis. These defects are lethal. When you are saying lethal, means they are not compatible with life. Whether you go to Tokyo, Japan, or to Sydney, Australia, these babies, there's nothing that can be done for them. So that when a report comes and tells you that there's alloboloplesencephaly, don't offer alternative message, because sometimes babies are diagnosed, then the obstetrician say, don't worry, maybe things will change, let's keep on, and then you end up doing a seizure, right? Yes, these things do happen. Or severe pulmonary hypoplasia, the mother is falsely reassured, and then they end up getting a seizure. But we need to know that these are lethal conditions. There's nothing that can be done to salvage the baby's life. These ones will cause major defects. It will now depend on the interpretation of the risk and the preparedness of the couple to look after a baby with defects. So this is sort of the management algorithm that we normally follow. So whenever we detect a defect, we want to know is it minor or major. If it is minor, and there is no surgery required, then it's just routine, and the timing of the delivery sometimes depends on the obstetric reason for minor conditions. Then if we think it's a surgical condition, then we have an MDT, where we gather all the necessary people. If it is an ortho condition, we gather the ortho. In an MDT, we discuss everything, including, is this something that you guys can fix? And if you fix, what is the outcome of these babies? So that we go back to the mother and give them informed counseling about the condition so that they can make an informed decision. Then we also discuss the issue of termination to say, should we offer termination as a viable option or not? Then out of that MDT agreement, we go back to the parents and tell them what the MDT will have decided. If it is not a surgical condition but needs the other specialties, the renal people, the renal pediatricians, you call them, the neonatal are part of the MDT permanent members because they receive these babies anyway. Then of course, if there is need for diagnostic testing, we do diagnostic testing because the association of chromosome abnormalities has a bearing on the outcome. Then the MDT counseling and also the family support counseling that they are given. They are counseled by the clinical psychologists, not once but several times, before they can commit to any decision, pregnancy defining decision. Then for major defects, we always want to confirm the lethal phenotype, confirm the diagnosis, genetics, the recurrence risk, counseling, and also for the non-lethal, it's almost the same way, but in this case, we'll be talking about treatment, bedtime, the neonatal plan pathway. This is all done under the MDT now. We now have a well-established multidisciplinary team meeting that discusses these cases, where we discuss together. Where prognosis is poor or treatment is not pursued, that's where we introduce supportive care versus termination of pregnancy. The termination of pregnancy we are discussing, we don't prescribe it. We offer it as an option, and the couple, after counseling with the counseling team, they will make their informed decision whether they want to keep or they want to terminate. Then the delivery planning, again, depends on the condition, and also the discussion of the MDT, and also our advice as fetal medicine experts to say when should these babies come out if everything is stable. Then the termination pathway, it's a legal pathway which we follow. I should just show you some of the pathway, but we try to do non-directive counseling, and our team, counseling team, always reinforces this when they talk to them. Of course, there's documentation that takes place everywhere. So these are the counseling essentials that we follow through there. We sometimes have to repeat the scan because they may request that we see them again. Then we discuss. Then we also explain the issues of the survivability, the disability, and the uncertainty, because there are certain conditions that are very uncertain, where you don't know what is really going to happen to these babies. Then, of course, the genetics, the MDT input, including the counseling sessions, then the delivery and the newborn. And let me emphasize that our MDT extends to the delivery period, because we also discuss the outcomes. The reason why we are doing this is we are so building the MDT to the capacity, to a level capacity, kind of. What I mean is, fetal medicine is still a young field in our country. And the experience of prenatal diagnosis and linking them to the true outcomes. What I mean by true outcomes is, yes, books may tell us that gastroschisis survives by 80%. But in Mupilo Hospital, what is the survival? Because this is the level of counseling we want. This is the level of MDT discourse we want to say, yes, books tell us that gastroschisis have a good outcome. But when a baby is born at Mupilo after prenatal diagnosis, do they have an 8 to 10% chance of going home? This is where we want to zero it up to in terms of the level of our other colleagues, the pediatrics. We know these outcomes. We've been following them for years, that they are not good. But our surgical colleagues won't be having their true outcomes of the prenatal diagnosis. So they'll probably be having these very high figures of selected cases. So they will tell you they do very well, they do very well. So we say, okay, let's follow the outcome and present them. Then we know after 2 years, we'll all be thinking the same kind of, right? Because we'll be sharing the true outcomes of what is going on with our patients. Right, so to just round up, so this is the procedure we offer to, because people may wonder, if you see these defects, the termination, how does it happen? We offer feticide. I'd attached a video there, but I've decided I will never share this video again after people said I traumatized them in one of the presentation. So I just wanted to know that what we do is we unfortunately we have to do this. We introduce KCL into the baby's heart under ultrasound scan guidance. We put our needle there, and we stop the heart using KCL or olignoken, depending. It's a traumatic procedure, I think, for everyone. Including the registrars. They don't know it now because they've been enjoying the procedures, but I think later on they'll also be affected in a way, because, I mean, it's not a nice procedure to do, but we have to do it because it's part of our work. But that is what we do, because people may wonder, say, you are diagnosing for what? We're diagnosing so that those who choose termination, they can also terminate, because it's also a lean therapy for some couples. Right. So this is the algorithm. Systemic scanning with saving of the images, because sometimes you may want to look at them. Then we define lesions, look for association, choose the right genetic test, counseling, prognosis options, MDT pathway, then the birth of the baby under the MDT cover, then the newborn care for those who keep or the defect that need corrective surgery. Some patients we transfer them in utero to centers that offer the surgery, the ones we diagnose in utero. Then, of course, the outcome capture and the risk of recurrence, we always discuss it. Thank you.